Well, hello and welcome to today's learning session on utilizing service and resource sharing approaches to address statewide challenges. Hopefully you're in the right place. Before we dive into our topic today, I wanted to share a few general logistic reminders. Participants are automatically muted as they join, so please use the chat to enter any questions or to connect with other participants. While we do have time allocated at the end of the session to respond to any questions, we are happy to answer them as we receive them as well. We would love to interact with you during some of the group discussion portions of today. So we do encourage you to keep your camera on if possible. And the session will be recorded and shared either on the PHAB website or through a follow-up email after the fact. Lastly, closed captioning is available within Zoom should you wish to turn that setting on. To enable closed captions, click on the CC button in the meeting toolbar as shown here in the screenshot. Please note that this may vary depending on the version of Zoom you're using, and you can hide the captions at any time by clicking the closed caption button again. So hello again, I'm Travis Parker Lee. I use he, him pronouns, and I'm a senior specialist at the Public Health Accreditation Board, or PHAB. I'll be one of your main presenters today, and I'm joined by my colleague, Grace Gorenflow, who is a subject matter expert in service and resource sharing and is working with PHAB as a consultant on various topics. So always happy to have Grace join us for these sessions and for all the great work she has done with us. We are a relatively small group today so far, so I think we do have a little bit of time. If you want to go ahead and take a moment to introduce yourself in the chat by providing your name, your organization, your location, and then if you have a question about anything related to service and resource sharing, you can add that in as well. And then as you're doing that, we are also going to two quick polls to better understand who is joining us today. So bear with me for one moment. And hopefully you should see the two poll questions on your screen. And I don't think you can see the results yet, but I'll make sure I share those momentarily. All right, I'm going to keep that open as we go through the next slide. Before our time today, we did want to aim to meet the objectives you can see here on the screen, as well as the provide content in the agenda shown as well. We're going to start with just a brief grounding to make sure we're all on the same page. So provide an overview of our service and resource sharing definition and then the approaches that we have used in our work. But then really spend the bulk of the time hopefully having group or small group discussions with some discussion prompts. All right, I'm going to go ahead and end the poll. And it looks like majority are from state health departments, which is great. Hopefully that was the audience we were aiming for today, but also have some local health departments and some other folks joining us. And then pretty almost evenly split between centralized, decentralized, and mixed. So also very good for us to keep in mind as we're chatting today. Thanks for doing those polls. So here's our definition. Again, just to keep us on the same page and to ground us. Service and resource sharing among health departments is when insights, expertise, techniques, and tools are shared across organizational boundaries. And that can be things like a population served, a specific service area within a state, or district or distinct government jurisdictions. Sharing empowers public health departments to work together to protect and promote the health of the people they serve more effectively and efficiently. And by sharing those insights, expertise, techniques, and tools, health departments can accomplish more than they could do alone. Ultimately, this does enable a reduction in inefficiencies and ensures services are delivered to those that need them most. Lastly, it guarantees that all individuals, regardless of their location, have access to the foundational public health services, which is an essential component for driving transformation, modernization, and effective responses during public health emergencies and emerging threats. So we have found it useful to categorize the different ways that sharing occurs to better understand its many variations, assess the application of our tools and technical assistance to the different approaches, and also identify any new tools or technical assistance for us to apply. So here on the screen, you'll see 3 approaches. And what we mean by that, it refers to the level, whether that's state, regional, or local, where service and resource sharing arrangements are occurring. Please know that it is possible that a sharing arrangement falls into more than one of these categories. But for our purpose, it is not important to make determinations about the right category for arrangement. Rather, this is a broad conceptual framework when thinking about service and resource sharing arrangements. For this learning session, we hope this provides you with a general understanding of different approaches, and perhaps it will prompt ideas about innovative sharing arrangements that work well in your state. And as we touch on each of these, keep in mind that we do have examples of all of them that we have shared in previous learning sessions and webinars if you were able to join those. But please feel free to ask for specific examples in the chat as we're going through them. We can either respond there, or if the group would like to discuss any of them, we're happy to pause and have a group discussion as well. So state level or system-wide approaches refer to services and resources offered by a single centralized entity and or a state health department strategy to promote arrangements among local health departments in the state. Some examples of this can be a service or resource that is shared to and among all in the state, incentives provided by a state entity that encourages different types of sharing arrangements, or a state entity that funds a service for all in the state. We've seen this show up as state health departments distributing categorical funds across the state differently. So fewer local health departments receive certain resources and then are obligated or encouraged to work with others to make sure those resources aren't put to waste. Excuse me. Regional and district approaches refer to services and resources offered by an entity that serves a defined subsection of a state. So these can be regional or district offices, again, depending on if you're centralized or decentralized, that can have different implications on your work. A state entity funding specific program services, or a regional entity developed by local health departments providing services amongst themselves. And we've seen this show up as partnerships, like formal coalitions, and even council of governments models. Local approaches involve 2 or more local health departments working directly with each other to share services and resources, whether they're funded or incentivized by the state, as described before, or purely on their own volition. You can see some of the examples here on the screen. That can happen on an as-needed basis, if they're sharing services and resources, whether they're purchased or just sharing them amongst themselves, or if they're fully integrated entities. So speaking of sharing among local health departments, national work around all of this began with an almost exclusive focus on local health departments sharing with each other. And this spectrum conceptualizes a range of sharing from very loose informal arrangements on the far left to very formal, highly integrated arrangements on the far right. And moving along the spectrum increases integration, but it also reduces autonomy and adds governance complexity. I'm going to drop a link in the chat. And this is to a document with some more details around this spectrum. And if you would like to refer to it throughout the rest of our learning session today, please feel free to have that up on your screen. So now I'm going to turn things over to Grace to kick us off on our next part of our session today, focus on your challenges and to hopefully brainstorm some solutions. Grace, if you want to take it away.
All right, great. Thank you, Travis, and hello, everybody. Thanks so much for joining us. And hopefully everything that Travis just reviewed really puts us all on a level playing field. What we really hope that you took away from the background that we just went through is that sharing, when we talk about service and resource sharing, it can take so many different forms. And this is something that is particularly important in this day and age as many states are moving to modernize and transform their public health systems. If you, as state is working to make sure that all of the foundational public health services are available to everybody, regardless of where they live, it may well take some thinking about how to distribute resources differently. And so we have seen a host of examples. We consider sharing to encompass quite a large universe of different kinds of arrangements. So we're really hoping in today's session to hear from you all, and we've got a couple of things lined up for conversation. And we wanted to start here. We would really like to hear from you about any sharing arrangements that are happening at the state level or system-wide level, whether you're in a state health agency or a local health department. If you are engaged in, or if your state is engaged in doing things differently, distributing resources differently to make sure you can be as effective and as efficient as possible, we would love to hear that example. And either if something successful, that's great. We always want to hear about that, as well as any lessons learned, any advice you have for others, as well as any challenges. And anyone who is interested in putting forth a challenge, we would love, in addition to us talking about some potential ways to address them, we would love to hear from anyone on the call about how to address them. So why don't we start right there? And Travis, can people unmute themselves?
They can.
Okay. Great, thank you. So please either use the raise hand icon, or you can put something in the chat, or you can even just unmute yourself and start talking. So I'll stop talking and see if we have any takers. Oh, great. Jeff Ketchel, Washington State. So glad you are going to speak. Some You all, maybe some of you participated in a webinar, a couple of webinars ago, where Jeff spoke about some of the fantastic work they're doing in Washington State. So, Jeff.
Actually, it's a question for the group, or for you, Grace, actually, too. And so looking at it from a state perspective, and we're a decentralized state in Washington, and we definitely, in our statute for foundational public health, our legislature wants reports on new service delivery models, with shared services really being the primary part of that definition of what service delivery means. But and so we definitely have examples, local to local, and work is being done tribal to tribal and tribal to local. But when it comes to the state, as we report every year on our work and describe shared service situations and arrangements, one area of discussion and occasionally disagreement is if a state is providing a service for locals, is we lot of our parts of our system say that's not a shared service, that's a centralized service. And so like in Washington State, all radiation protection is done by the state. Locals don't do any radiation protection work. For the most part, almost all public health lab work is handled by the state. Centralized data systems. I use the word centralized, but and so when we're like doing our little check boxes and filling out our forms about shared services, this came to a little bit. It wasn't a big disagreement, but and one not a hill to die on for sure. But just anyway, I mean, is anyone else out there thinking about or Grace differentiation between shared versus centralized and you know, so how or how else would you quantify work that states provide to assist or for locals or for tribes? Thanks.
What a great question. And I'm glad it's not a hill to die on. I'm going to hold off on commenting for a moment and really invite others to chime in and see what they would say. And so just to say it back to you, Jeff, this has come up because of the requirement for you all to report to the state legislature about what the state is doing in terms of shared services.
Well, the system. So
Sorry, the whole, okay.
Yeah,
yeah. Right. So it's every level, including, okay, great.
Yeah.
All right. Oh, I almost called on somebody, but it turns out it was my cursor with a hand. Okay, anybody?
Potentially to add on to Jeff's question, we've actually heard the reverse too from centralized states that we worked with, probably not surprisingly, that, you know, obviously they provide services throughout the state and it is considered a centralized service. And we have seen that some of the locals in those states have a hard time understanding what it means to share when it's already provided. So just throwing that flavor in as well, since it's seems like it's happening at both levels.
Or if anyone has an opinion, I'll take opinions that are not evidence-based at all.
Okay. Well, I can start with my opinion, and or I can even just tell you how we approach this kind of thing. Despite the fact that we've got those that list of approaches and we have the spectrum, we don't try to classify things because it's not unusual when we've been asked and somebody said, well, would this be considered, you know, local to local or regional or state? To us, it doesn't really matter because we look at these things and our work is focused on how can we help health departments be as efficient and effective as possible. Now, that said, I personally would say that what you're describing is shared. It just happens to have been in place for a while. And my sense is from the examples that you gave is it doesn't make sense. It's not efficient or effective, for example, for every local health jurisdiction in the state to have its own laboratory capacity, right? So at some point in history, I would posit that that's why certain things are done at the state level and others, it makes sense to have it, other services and capabilities, it makes sense to have them at the local level. So I think, and so I would also say, my opinion, when you report on these things, if you don't already, I would make that point. That the reason the state is in the business of doing these things is because it's the most efficient and effective way to make sure that everybody's served.
Yeah, and so I'm always trying to find, what's the fuzzy line between things. I don't necessarily need a solid line, but at least a dash line. And um, I mean, shared services are more of a, I don't have to do this, you don't have to do this, but we've decided to do this together. With a lot of these centralized services, while they might not be mandated, and some of them are like radiation work, but like you said, it just makes the most sense to have, because of the high capital costs of a public health lab, to not have, many multiples. And so, so that makes sense. But then but there's other things where the state is doing things for, say, locals, where it's not a mandate, or it's not something, naturally, but that definitely, want to like, if a local jurisdiction doesn't have much in the way of epi, or assessment capacity. We have epis specializing in all kinds of different programs, and so they'll put together all the data for a county on chronic disease, and put it into tables and charts, and from all the available data sources, and here you go. So that could be a shared service, but we yeah, it's a small tension. And just yeah, if anybody else has any experience with that, or remember later, I'll put my email in the chat, because I'm always looking for better ways to define foundational public health and just make things, create clarity. So yeah.
That makes sense. Now, I am going to be speaking out of both sides of my mouth when I say this. I could probably argue the other way also. So, but for what it's worth, just because of my universe and the way I see things, that's, yeah. All right. Thanks, Jeff. Does anybody else want to add to that, or does anybody else have a similar situation? And another opinion?
Hi. I don't know that I have a different opinion, but in Utah, we're also a decentralized system. So with our data modernization efforts specifically, that's what I'm the lead on, is DMI. We are also looking at that. So like, for example, one of our projects was to do an RFP process for a public health focused electronic health record. And many of our local jurisdictions are rural or very remote and don't necessarily have the funds to do an RFP process to look for an EHR that could work for their public health system. So we did a statewide EHR RFP, and then are able to now offer that as a cooperative agreement for any locals that want to participate with the EHR. They still have to pay for it, but we've done the process of vetting and designing, so that they can just bring it on and utilize and customize it for their jurisdiction. But then having multiple jurisdictions on the same EHR will also help with interoperability and data access and data sharing that we're looking for as well. So similar to what Washington is doing, where we're looking at resources, and if it's easier for the state to do something and then allow the locals to opt in, so they still have that sort of control over what's happening in their local jurisdictions. But then we can aid where we can with our resources.
Wow, that's a great example, Katie. Thank you for sharing that. And something else I really love about that is not only, I mean, as you said, not only is it helping any individual health department, but then they're also being brought in as part of a larger system, which has a lot of other benefits. Great, thank you. And then also along those lines, Katie, can you tell us a little bit more about that in terms of any challenges that you've encountered, or any advice you'd have for others who might want to do that same kind of thing?
Yeah. So one one of our biggest challenges. So part of the process that we went through when we were looking for this was that we went to all of the local health officers first and asked if this was something they would be interested in to make sure that we had the buy-in before going through implementing the whole process. And multiple of them, well, they all agreed that it would be a good idea, but we had multiple sign up as early adopters. So they would be the first ones to sign on once we had the process complete. But then something that was more of a challenge was helping the locals be patient with the statewide procurement process, because the bureaucracy takes a while. So working through the contract negotiations with the provider, we also had locals on the panel that selected the provider, so they had a voice in what it would look like, what design elements they needed, and all of those kinds of things. But then the negotiation part has taken months for us to be able to complete. So now we're at the stage where the locals want to start using it and are excited and ready to go, and our early adopters are lined up. And we're like, okay, we have to be patient with procurement so we have all our ducks in the row first. So as far as ways of advice, having the locals on in the selection committee so that their voice is heard, and it's not just something that's like, hey, the state thinks this is best for you. And then making sure you have those early adopters and folks ready and willing to take it on so that you have a very applicable use case right off the bat. And then, yeah, by way of caution, be patient with the bureaucracy.
Do you send out routine communications letting them know the status? Like even if it's nothing's happened yet or we're still waiting?
Yeah, so we have a data modernization coordinating council that has 3 different tiers in it. The top tier is the executive tier with the local health officers. They meet every other month. We have a leadership tier that has like our local EPIs and supervisors and others that want to participate, and they meet every month.
Okay.
And then we have work groups that meet ad hoc from there. So that's where most of our communications and updates go out.
Great. Thanks, Katie.
Yeah.
That's great. It sounds like you're using a phenomenal process. And good luck, hopefully sooner rather than
Yeah.
later.
Thank you.
Yeah, sure thing. John, thank you for your comment. And I'm wondering, anything you would like to add or elaborate on?
Only that all the programs are pretty well driven at this point by state of Ohio. We are still in some of our what we call silos where we need to connect ourselves to the local networks, the regional up into state. Some of the programs that are still keep us in our silos would be food scarcity, lead in pipes. You can look at the Lake Erie harmful algal blooms, and we're still trying to sort a number of things out. I gave that website for Lucas County. It's about 400,000 people, so it's a medium to a higher sized health department. And we continue to try and link up resources, but it's more state driven. And state is also in food would be the Food Safety Modernization Act of January 2011. So it's just an example, a template, and people, you can see people, you can talk to them. I get the sense of on this webinar that many of the states that are participating are going through a process that we went through perhaps 20 years ago as we were merging into larger entities. But it all is seems to be driven by the desire to be much more efficient, whether it's those green dollars or the resources of people, places, and things.
Yeah, actually, I was interested to see only 114 health departments in Ohio, knowing that the number used to be a lot bigger than that. So given that, would love to hear any comments you would have on, you know, you said that you're being pushed to become more efficient with your resources. Anything that you could tell us in terms of where the state health department has really facilitated that kind of effort, as well as anything to the degree that you're comfortable sharing that maybe is not as effective in a strategy as it on the ground as it might feel like from the vantage point of working at the state?
I'm speaking as a private citizen. I've left that health department about 5 years ago. Do contact them. They can be used as resources. What I am going to make is a statement. I come from the food industry since 1973. And when you think of food safety, FSMA, that Food Safety Modernization Act of 2011, ahead of that, 10 years ahead of that, European countries, Pacific Rim countries had the global food safety initiatives and lots of verifications and validations. So what that being applied to food companies to keep everyone safe from a food safety standpoint, you got into the practice of designing systems, pooling resources, utilizing resources under verifications and validations, much like what PHAB is doing or has been doing with health departments. And of course, the state of Ohio has its history of all those 114 health departments, if my memory is correct, had to be PHAB certified by 2020, or the next year they might lose 1/3 of their funding. And then the year after that, they would lose another third. So there's some comparisons there, but I'm just speaking as a private citizen. But many of the things in public health that perhaps other states on this call are going through, Ohio went through that 20 years, 25 years ago as mergers were occurring. But at the same time, when General Mills got me started in the food industry in 1973, and you see all of the changes in the food industry since then, you can understand the importance of really optimizing your resources, whether it's those green dollars or soft dollars or people, places, or things. Especially when you get into, there's a connecting kids to meals here in town. Lots of need to have healthy kids, food in their stomachs so they can do well in schools, and then they do well as citizens of this country. Anyway, my comments are private, but the people in that health department can certainly be contacted, and they will provide assistance.
Okay, great. Thank you, John. And Ann Goon, also from Ohio, I really appreciate your comments. So now it's down to 112. And I am going to put you on the spot, given your history and given your current job.
Sure.
Hello there.
Hello.
Thank you. What would you add to the conversation in terms of what really seems to be helpful in terms of state activities with sharing services, as well as what's not so helpful?
Yeah, I mean, so there certainly have been things done over the years to try to help sharing. I mean, I think it occurs in some parts of the state more naturally than others. In Southeast Ohio and in Northwest, where you have more smaller, more rural counties, they've often shared for many years, and it's not limited to just public health. When I was actively working as a health commissioner in Northwest Ohio, we had 6 counties that shared one epidemiologist. We all commonly provided services in each other's counties. For example, one would be the grantee for reproductive health for 2 counties. Another county would take over 2 others, and so there were other kinds of arrangements like that pre-existed any of the health commissioners that were in place at the time that I was there. And it was also common in mental health services and developmental disabilities in county commissioners. I mean, so it was a part of the culture there. And so there have been a variety of different activities over time, none of them sustainable really, that the state has periodically made money available, or maybe gave additional consideration to somebody who had proposed a project that was a joint project with another county. I think I think one of the best things that happened was probably back in the Kasich administration, when there were local government innovation funds made available, not just for public health, actually for any sector of public and or private together. And so, that's where, we were able to apply as the 6 counties in the corner of the state to do a feasibility study to look at how could we further build and expand the services we shared. Another great, and that resulted in a council of governments being formed that I'm now the executive director for. But another project that happened at the same time out of that funding source was about 10 to 12 health departments coming together with our state Ohio Health Association of Health Commissioners, got funding for a feasibility study to look at a shared electronic medical record and billing system. And so, they got that started out with somewhere between 10 and 12 health departments and the AOHC. Now it is up to at least 35 health departments, maybe closer to 50. They're all part of that. So basically, it's for their clinical services, and the types of clinical services that each one of those health departments provides is different. Some are full primary care clinics, and others just do immunizations. And they're of all different sizes too, from a small one, several small ones down in Southeast Ohio, to ones that are in major cities. So that really has grown over time. And so it wasn't public health as a state health department helping with that. That was actually the state of Ohio government making those funds available.
Yeah.
And there were certainly learning curves along the way with that project. But now they all function as multiple practice locations of the same practice. And so there's a practice manager, there's a shared electronic health record, integrated billing system, and they all share the same policies and practices around those clinical services because they have to. They're all part of the same practice. So I think that's one of the big ones. We did receive help along the way as we were forming our Council of Governments. The state at times did give us additional dollars to as a direct request, basically, to help us. And sometimes they found some creative ways to help us in that process. But it's more, I think here in Ohio, it's more locally driven than it has been driven by the state.
Okay, yeah.
Having been now in public health in a leadership position of some sort for 20 plus years, I would say that there was more, and there has been, even with the requirement to achieve accreditation, more of a stick approach than a carrot approach. The mandate was passed without any funding made available, really, without any assurance that we truly would get any additional money. One of the things they worked out of the state budget was doubling the state, what we call the state subsidy, which went from 19 cents per capita to about 38 cents per capita. So still, like number 48 or 49 in the nation, not a big investment. And so we've all gotten better. It was an increase. It was an increase. We've all gotten better as a result of accreditation. But it hasn't yielded the investment that everyone had hoped it would.
Yeah.
But I recognize from my involvement in things at the state level, I know the limitations that the state health department faces too.
Yeah.
And so I'm not surprised we haven't gotten further, given our state legislature. So
yeah. Well, thank you. I really appreciate the examples that you gave also. Super helpful. Thank you. So, all right. So why don't we go ahead and Travis, move on to our poll. And then also I'm going to ask folks, John put a question in the chat box. I'm just going to ask folks if they would respond to that question, please, as you see fit. So we wanted to delve in a little bit more deeply with respect to the foundational public health capabilities. And so we've got a poll, another poll that we would like you to quickly take. And we're wondering of these of these capabilities, which ones would you say, and you can vote for however many you would like, which ones would you say are the most difficult to ensure statewide? You think about your state and the degree to which people all across the state are or are not supported by or covered by these capabilities. And then we will have a bit of a discussion after we've had the poll open for about a minute or two. You will see as you move down the list that we have parsed out the organizational competencies because they're sufficiently different from one another. And that's why we did that. Anyway, we think there are probably some important distinctions there.
Grace, what do you mean by difficult?
Where you would just say that individual health departments or
I mean, I'm thinking of like politics, money, priorities, conflict.
yes.
I mean,
So
I would answer.
yeah, where you're the ones you're least likely to see
Okay.
uniformly.
I'm overthinking it probably. Okay, thanks.
Okay. Not you, Jeff. All right, great. We've heard for about 20 folks. Let's keep it open one more minute, Travis, just so everyone can really consider these, and then we'll see what rises to the top at 22. Travis, when we close this, is there a way to show them in order? Like, okay.
Yeah, I'm not sure if it will show it in ranked order, but I'll try once I share the results.
Okay.
All right, we'll do 20 more seconds and then close it. So last call for those votes. Going once, going twice. All right, thank you all for participating. It doesn't look like I can rank it by percentage, unfortunately.
So what we see that's rising to the top, performance management, equity. Let's keep. Sorry, I need to scroll down.
Yeah, it looks like it's the workforce development and human resources part of the organizational competencies are the top three.
Okay, great. Thank you. Okay. All right. So can we go to the next slide, please? And thank you all, those of you who weighed in on that. We thought it would be really interesting to hear from you all when we think about foundational capabilities. And let's start with let's start with equity. Okay. First of all, it'd be really helpful. I mean, equity is very broad, as we know, and not only in this framework, not only does it show up as a capability? How it also shows up as being, for lack of a better word, foundational to the whole foundational public health services model. So when we think about equity and that capability, first of all, it would be great if anybody would be willing to speak up and let us know what you think about when you think about equity. And then let's talk about, okay, is this a capability where we could share services, and what might that look like?
I'll start.
Thanks.
So one of the things that I do here through our Council of Governments is I'm actually contracted to facilitate our accreditation learning communities across the state. And so this conversation that we've been having about equity is exactly there because of the diversity of counties and cities that we have. I mean, you've got a place like Columbus and Cleveland, very diverse. And you've got places, you know, in other parts of our state where, you know, they're 98% white. You know, with no ethnic groups, no, you know, not significant diversity. And so we've really been having a lot of conversation around, well, what truly is equity? And what counts as equity in one county or jurisdiction could be significantly different. But there's enough of us that are similar that, you know, we can at least hopefully arrive at a place where for rurals, we can say, okay, are these the equity considerations that you're looking at? And is your community health assessment strong enough to capture that? So in your process, you identify truly, well, what are the drivers of health inequities in your county? So if it is poverty and it is education and it is something else, do you clearly call that out in your CHA? Because then you can drive your your equity efforts around that, and you can clearly demonstrate to PHAB why it is that you're addressing this in your equity efforts. Because in your county, that's what drives inequity. In another county, like I work with Cuyahoga right now, you know, it's much easier. I mean, we've got certain zip codes and census tracts we can point to where we know, and they have lots of great data. You often don't have that great data in smaller jurisdictions. So a piece of it is we're trying to get to this broader understanding of what equity is. It's not just race and ethnicity, and thinking about that circle of intersectionality, thinking about other things that determine power and the distribution of power in your community, like what religion are you, or do you go to a church at all? What school do you go to? What kind of job do you have or not have? You are you male or female? What about if you're LGBTQ population in a rural county? You know, you get treated differently if you even feel comfortable coming out at all. You know, so just trying to broaden our understanding of equity. And I think there are pieces of that can be done through a shared lens in helping people think through that, whether that's providing training around coming to that understanding, having a model that you can, you know, pilot in rural counties that others then can try. I think the place where data modernization would be very helpful is if we could get to the point where at the state level, they could provide that same granularity of data, you know, in a way that is helpful to everybody. It's there already for large jurisdictions because they have large portions of the population that you might consider diverse. But
Right.
when you get down to the city level, that's especially difficult, which many things are more difficult for small cities applying for accreditation. They just don't have that level of data. And you can't get it from many places, more than you used to, but not like you can for a county.
Great. So thank you. So it sounds like when it comes to equity, one thing to think about in terms of sharing would be to share the capability to analyze and understand what the equity issues are. If there is a training, if there is a group, could be the state, maybe it's also if there's an academic institution
Right, yeah.
that could help, but getting together to understand it, and then once you understand what the problems are, seeing what similarities you have.
Mhm.
Okay, great, thank you.
Yeah, yeah, because that could even then lead to, where one of the accreditation measures for reaccreditation is around how have you taken an evidence-based or promising practice and
Mm.
adjusted it for your population. I mean, so it could extend to that. So I think
Yeah.
there's opportunities for sharing, definitely, in developing the ability to do it, in sharing ideas, in co-learning and piloting, lots of things there.
Yeah, great, thank you. Yes, pilot sharing, pilot testing, and your results, absolutely, thank you. Other thoughts on equity and what a sharing strategy might look like if you're looking to make sure that that particular capability is present. Jeff?
Yeah, I would just add a great answer, Anne. That however you approach it, it's got that how you approach it is a shared service, because for the state or one of the associations to develop this in isolation really doesn't lend well with the values around equity. And so, I mean, at the core of equity is power, distribution of power. And if one piece of the system controls that power, then that's not really walking the walk in an equitable fashion. And so this work can be very slow. And our FPHS statute directs us to address health equity with our FPHS work. And we started we stood up a technical work group a year ago, and I mean they're still working on it. But it has components from all parts of the system together, and so we don't have an answer yet. But they come and have worked with all of our subject matter expert work groups and our steering committee and our project management team and others. And so it's a pretty comprehensive. It's very horizontal organization in Washington, so things move slowly, but things tend to be of high quality.
We'll keep an eye out on that, Jeff. Be good to see what you all come up with.
Thanks.
Yeah, thank you. Anyone else on equity before we go on to another capability? Okay, I'm going to say let's do accountability and performance management. So again, what might an SRS strategy look like in states where what you're trying to do is make sure that every community is served by a health department that's engaged in accountability and performance management?
I could certainly share what Ohio has done. It's worked in part. It's not perfect, but there are certainly some trainings that have been offered statewide, but most recently, and everybody's part of 21C is aware of this, the state provided subscriptions to Clear Impact software for all LHDs to use. And originally it was a certain number of subscriptions, and then they opened it up to an unlimited number. And so there are many health departments that are using Clear Impact. They've provided statewide trainings virtually on results-based accountability and the actual use of the Clear Impact software. I can tell you from having gone through some of those trainings and more having worked with health departments that have been through those trainings, there's a difference between attending a virtual training and actually being able to implement it well. I've worked with health departments that have implemented it. They're using the software, but they're not using it to its fullest degree, which isn't uncommon when you're using a new software product. But, the Clear Impact system is really designed around RBA. And so if you're not using that RBA approach to your community health improvement planning process and your strategic planning process, it makes it so you're not going to be using it to its full capacity as the software system itself. But just having that access to that is a big step up from what was available previously. So I think many health departments would agree that that was one of the best things the state could have done to help with an area that everybody, I mean, all the time we still get told that's one of the biggest areas for training needs is around performance management and through the accreditation learning communities that we do.
Great, thank you. And I think that's also it's a good example of group purchasing, right? Something that you might not even have the bandwidth to figure out what a good system is, much less purchase it. So this is an excellent example of how to be more efficient and effective.
Yeah, I mean, and what we're trying to do, I think there in Washington State at one point when there were certain areas where you funded a certain health department to provide certain services across multiple counties. That's sort of how we're thinking about the actual use of Clear Impact and helping people get from a foundational level to a more practiced, more intense level. Is we're actually doing some accreditation learning communities next year. They're hands-on workshops with health departments that are super users, working with health departments that are struggling and trying to figure out how really to use it. But then also thinking of that as a potential shared service through a council of governments as well. Especially if we've helped you with your strategic plan and we've helped you with your community health improvement plan and identifying performance measures, well, then let's just go the next step and help you walk you through that too. So
yeah, that's a great point. You get the peer support.
Yeah.
As well, that is
very helpful. Yeah.
Yeah, great. All right, thank you. All right, well, I'm going to turn things back to Travis, and thanks especially to Anne and Jeff and Katie and John for your contributions. All right.
Yeah, and echo your thanks, Grace, and sorry for the behind the scenes stuff you just saw, but we did have a few other slides with content on them, but didn't want to cut the conversation short, so we'll make sure we include that in any of the follow-up materials that go out. But yeah, thank you all for joining today and for your participation. Really appreciate the time. We hope the information provided was informative and can help you support your work and is applicable to your efforts. Please be sure to connect with us on our social media accounts here on the screen. And we do invite you to provide feedback using the evaluation link that was, I think, just posted in the chat, but there's a QR code on the screen that you can use. And then lastly, if you aren't already signed up for e-newsletter, you can use the QR code on the right to quickly be added to our distribution list. With that, we are at the top of the hour. So thank you again for your participation today, and you may now disconnect. And we'll be in touch soon with some follow-up information.